welcome. How are you? Glad you're all here. And if you are watching this in the recording, welcome, glad you're here as well. So my name is Adelaide Meadow, and if we haven't met before, I am a traditional home birth midwife and a women's pelvic health educator and a movement teacher. And this issue or this, kind of topic of prolapse is one of my favorites to investigate and open up because I think it is one, it's at the intersection of my work, doing movement work, pelvic health and midwifery, but it's also so commonly misunderstood and kind of wrapped in this mystige of the contemporary medical culture that is full of a lack of trust of women's bodies and a ton of misinformation. So I'm really excited to be working through this. The format of this workshop will be, we'll go through what I consider the three foundational principles or the three keys to supporting pelvic prolapse healing. And so we'll be going through those in the order of alignment and bony alignment and posture. We'll then be talking about diaphragmatic breathing and pressure control, and followed by functional strength and functional movement. We'll move through in that order. And if we have time, I feel like I should have said 4 keys, and the last one would be orgasm and understanding sexual health and the movement of the cervix in relationship to arousal and how that can be supportive for prolapse. However, I thought that might be a little much to get to in the hour, so we'll see what we get through. Okay, so initially, let's talk about what is pelvic organ prolapse. So pelvic organ prolapse, and why I refer to it in that broad way, is because there's several types, but we're gonna just begin. It is the destabilization and the movement downward of any tissues within our pelvic bowl. So the destabilization and the movement downward of any tissues within our pelvic bowl. So how that can look and what that's often a result of is childbirth. I've worked with many women who had prolapse and prolapse symptoms that were not as a result of childbirth. So this pertains to a lot of us. And why this is generally occurring is due to a lack of support in the tissues, right? And why that lack of support might be occurring is what we'll be talking about. So women have, for the most part, 3 common types of prolapse. And one would be a uterine prolapse, also called a cervical prolapse, where the uterus is moving down into the vaginal canal. So if we think of our vaginal canal like a tube, right, the uterus is moving into the tube. So if the vulva is here, the vaginal opening at the bottom, the uterus is moving down. So placed within the pelvis, right, our vagina is usually about at the level of the pubis. So we have the descent of the womb, which is held here, moving down into the tube of the vaginal canal. That would be a uterine prolapse. We also have a cystocele and a rectocele. We also have urethral prolapses, but we're not going to talk too much about those today. But a cystocele, or a bladder prolapse, and a rectocele, which is a rectal prolapse, occurs not when anything is inside the vaginal canal, but rather where things are encroaching from the outside into the vaginal canal through pressure. So in a bladder prolapse or a cystocele is where the bladder, specifically when it is full of urine or filling with urine, will press and will collapse somewhat into the vaginal wall. So you have this sort of external tube that bladder prolapse is pushing. And so when you reach up into the vagina, specifically anteriorly, you'll likely be able to feel that bulging or that pressure, right? That would be a common bladder prolapse. You also might not be able to feel it in all in all postures or all arrangements, but maybe just in a posture that would put pressure on the bladder. Something like that might be forward folding, right, where you're actually sort of hinging down. And we're going to look at that when we talk about structural alignment. And I know this was a question, which how would you know if you had a rectocele or a cystocele? Also, difficulties with bowel movement, specifically postpartum, are often associated with rectocele. Bladder incontinence postpartum is associated with cystocele. And we also can have some degree of multiple types of prolapse, right, at the same time, right? It doesn't have to just be one or the other. And what's unique about that, so what's good about that is what's going to be resolving to one is likely also going to be resolving to the other, right? It doesn't have to be this like grand mystery of something being contraindicated for healing one type of prolapse and recommended for another. We can have a more holistic healing approach. So the first key to healing pelvic prolapse. And I might also say, if you're watching this, to preventing pelvic prolapse. So some of you, this is obviously very relevant for healing, but for those of you who are watching this who are birth workers or who work with women or who are pregnant or whatever, a lot of what we're going to work with here is also true for prevention of prolapse, right? And we know that this, as we manage our health, is generally true. Like, oh, I'm struggling with mineral deficiency. What's the treatment? Well, have more mineral-rich foods. Well, what's the prevention? Eat more mineral-rich foods, right? It's all, wrapped up in the same cloth. So let's talk for a second about posture and female pelvic posture. So the female pelvis is amazing and entirely distinct from the male pelvis, which I think is why this gets often overlooked when we're talking about women's health concerns, because the bones are entirely distinct, but we're not taught about those differences. So let's look at this handy female pelvic model. I'm going to do a little tour of the bones to begin. And if you'd like, you can palpate on your own body. We're not going to go too much self-palpation in this webinar, but palpate as I go along. But your pubic bone is in the front, your pubic symphysis. So you have, can you see this clearly? Yep. So you have the two halves of your pubic symphysis, right? And your clitoral hood sits generally right here, sort of right below this connective tissue band in the along the pubic symphysis. You then have this sort of top bone or the superior bone and the inferior bone of the pubic symphysis. If you follow along, that's top bone. We come to your ilium bones, which are these big wing bones of the pelvis. This is the interior face of the iliums. Walking all the way up here, we have these frontal hip points, right? Or our anterior superior iliac spine, or your ASIS. And if you reach down, sort of that knobby hip bone right in the front, right? Those are your ASIS bones or bony landmark. From here, this whole top ridge is called the iliac spine or the iliac crest on both sides. Moving around to our sacrum, and specifically first our sacroiliac joints. So those little dimples in your low back. So if you reach around and feel those little dimples, sometimes they're tender. These are your SI joints, and the S stands for sacrum, the I stands for ilium. So where they come together, and you can see this kind of cartilaginous disc on the model, right? That also occurs. And what's unique about the female sacrum and the female pelvis, or there's several unique qualities, but the first we'll talk about is the mobility of these sacroiliac joints. So the ability for these joints to have the sacrum knock in and knock back, knock in and knock back. And while this is a little exaggerated because this is a model, we don't have quite that much range, but we do have this hinge capability. And this is because our pelvis by nature and from the bony arrangement is designed for mobility as well as stability. So stability, because it is the chalice that's holding all of our pelvic organs in the base of the spine, and mobility to enable childbirth. So for example, the requirement of the sacrum being able to move backwards, we can see that that obviously would create more room in the pelvic outlet than if it was drawn forwards. So this knocking back of the sacrum allows for more space in the pelvic outlet. So we have these mobile SI joints, and then our sacrum moving down, this, people often call it a flat bone. It's not really that flat, but this sort of slightly concave bone, concave towards the front, right? With our coccyx or tailbone at the bottom, right? And then just a short hop, skip, and a jump from our coccyx to our ischial tuberosities, or to those sits bones. So if you're sitting now, just like wiggle your butt and you'll feel these two little sits bones on, that's likely what you're sitting on. And it sits SITZ, or ischial tuberosities, right? And then from there, you'll notice the sits bones are actually connected to the inferior portion of the pubis, right? So they come all the way back up. On the sides, we have the acetabular cup, or the hip, like the socket, and then the femurs would sit within the socket. So a little overview of the female pelvic bones. From here, let's talk about the placement. So what is often shown as upright is this shape, right? So this sort of verticality where we can see it's oriented towards the midline, so to speak, or towards a vertical axis. This is not neutral for the female pelvis. And if you follow my content or familiar, you know I like to go on this rant about why we need to untuck our tailbones, but we're going to talk about how that's related to prolapse. So if we're in this uprighted shape, right, all of our pelvic organs don't have a floor to work with. And what I mean by that is these inferior bones of the pubic symphysis, inferior meaning they're magical, they're not inferior to anyone or anything, but this means they're on the bottom, superior on the top, right? So these inferior bones are designed to actually create a bony floor, so to speak, to support our organs. So in a neutral, sorry, I'm a little close to the screen for this, so it'll be a little easier if I back up. So the neutral for the female pelvis is in this tilt. That's about where the female tailbone could live. So in this tilt, we're allowing for there to be traction between the pubic symphysis and the tailbone, right? We're allowing there to be this spaciousness, because simply in the act of tipping the pelvis forward for many of us, right, and untucking the tailbone, we're bringing more spaciousness into the pelvic floor. Okay. What we're also allowing for is then the bottom to have bony support. So now, if you kind of look from the side, the pelvic organs can rest, right, on the floor of the bones. If we have this tucked tailbone, meaning tailbone moving in, uprighted pelvic posture, uprighted, so to speak, right, we are creating this like slide or funnel for our pelvic organs to actually move down and out of our pelvis, which is pelvic organ prolapse. So from a bony arrangement perspective, having this anterior tilt, which you can go back and watch my reel about why I hate calling it an anterior tilt, anterior meaning forward, but also it's only considered anterior because the standard is the male standard. So this considered upright, well, this isn't upright for women. This is posteriorly tilted or backwards for women, and this would be considered upright. But that's semantic, and not that language isn't important, but for the purpose of this course, right, we're going to call this an anterior tilt. Just know that that's misogynistic language for yourself, right? And that is therefore creating more support here. Also, when we have this anterior tilt, this, adjusted neutral female pelvic posture, we have a much greater ability to move the tailbone backwards. And when we move the tailbone backwards, we can start to create some support and some tension. And what I mean by tension is not like squeezing, but tone, meaning like if you were to take an elastic band and stretch it slightly, there'd be a little tension on the band, right? And that tension is created not by things moving together, as opposed to tension in this circumstance, where that's created by things actually moving apart from one another, like that rubber band. So being in this shape can allow for that tension to be regained between our tailbone or our coccyx and our pubic symphysis, therefore giving a little more support and tone to our pelvic floor muscles. When we are in this shape and the tailbone is moving forward, if you look, I have this little string here that's a little stretched out. So like that would be taut, but obviously that's not how it goes. But this little string, right, is indicating like, oh, if this is happening, there isn't a lot of tone here. So the tailbone is tucked. We have this slide shape. The bones aren't there to support you. And then there's laxity in the tissues. And this is the perfect recipe for creating an unsupported pelvic shape from just the basis of how you're standing, right? And then add, and we'll get into this when we talk about functional movement, if then we're adding weights or doing anything that's like exercise related in this shape, we're then significantly increasing the likelihood of pelvic prolapse. So many of the women that I have seen with pelvic prolapse who haven't given birth have been Pilates instructors, bar instructors, and competitive weightlifters, right? So some of the fittest women, right, are often experiencing some of the most significant non-childbirth related prolapse symptoms, largely due to this lack of understanding of the unique qualities of the female pelvic bony structure, and then subsequently the soft tissue, musculature, and organ structure that is supported or maybe not supported by the bones. Okay, so bony alignment basics are having this adjusted posture, this adjusted female anterior tilt, so that the superior or inferior parts of the pubis can be supporting for the organs, and then having that tailbone moving back. When we say tailbone, it's actually the whole sacrum, right? That is pivoting, where the top of the sacrum is tilting forward. So therefore the bottom of the sacrum is tilting back. I just want to be clear about that, because some people are like, I can't like move my tailbone alone. And it's like, you're correct. If you can't figure out how to do that, join the club. I can't either. But just for for our brains, often saying tailbone back is clear, right? And if we are set up in this shape, this is the beginning support, the first key to healing and addressing pelvic prolapse, because we can do all of the rest of it. But if this isn't occurring, it's going to be hard to resolve. So one reason why bony arrangement is so crucial, right, is the position that our bones are in dictates how the muscles and the connective tissue that are attached to those bones are able to do their primary functions. Meaning so in the pelvis, we have a variety of kinds of tissue, but we're going to talk today primarily about 3 types. One, which would be skeletal muscle, and then smooth muscle, also known as organ matter, right? But we're going to talk about the organs in terms of their muscular nature today, rather than their other functions, of which there are several, but talk about the muscular nature of the organs, and then connective tissue, right? So in the pelvic bowl, we have this bony tissue that we just discussed. And then the first part of tissue we're going to talk about is skeletal muscle, right? And skeletal muscle has a primary function that is mobility or supplicity, meaning supplicity meaning being supple. So the ability to both extend and contract is the primary function of skeletal muscle tissue. An example of skeletal muscle tissue would be like your bicep, your tricep, your quadricep, like the big muscles that you think of, right, that are moving the bones. These are your skeletal muscles, and that's their primary function, right? Then we have our connective tissue, which is non-vasculated tissue, meaning there's no blood flow in our connective tissue, right? And our connective tissue, I would also like to, refer to as our fascia, or our fascial, fascial system, right? So this all of our bone, all of our ligaments, all of our tendons, but also every cell membrane, what is surrounding every muscle fiber, every group of muscle fibers, is all made up of connective tissue, right? And rather than thinking about like, this is a tendon and this is a muscle, instead, imagine that your connective tissue is surrounding every single muscle fiber, every single group of muscle fibers, and that as you're going towards the bone, right, there's just less muscle cells and more connective tissue cells. So it's sort of tapering down and becomes a tendon, right, or a ligament, depending on if it's muscle or bony attachment, right? And then as it then moves into the next muscle, there's just like a greater density of muscle cells and less density of fascial cells. And so it kind of opens back up into what we would call muscle tissue. And so this stark differentiation between like tendon and ligament and connective tissue and muscle tissue is not based, I think it provides an inaccurate picture of how these tissues are actually interacting. They're sort of all ebbing and flowing in and out depending on the ratio of connective tissue cells to muscle cells. So there's, again, the image that I like the best is, if you have, it's sort of like a tube, right? So if you have this tube, right, and this tube is very ropey, it's like all of the connective tissue cells, right? And then all of the fascia, right? All of like a tendon or a ligament. And then as that, and we've probably seen the image of like, oh, that's at the joint. And then it like opens up to be the belly of the muscle. Those cells are still there. They're just now in between all of them are muscle cells. So it's like plumping up the muscle, and then they taper back down as it gets towards its next connection point, right? And so it is this forever interweaving between cells that both require movement, muscle cells, right? Tissue, right? Muscle tissue, right? And our connective tissue cells, which their primary action is stability, right? And so having this dynamic interchange between muscle tissue and connective tissue, between tissue that thrives on movement or supplicity and tissue that thrives on being able to glide over itself and be stable, this is the terrain, so to speak, of the female inner pelvic bowl, right? Both our pelvic floor and all of the tissues up within, right? So why I like to explain this is the more that we understand about our tissues, the less demystified we can be by the, these diagnostics such as prolapse. You're like, oh God, my bum is falling into my vagina, WTF, right? And instead it's like, oh no, there can just be like, what's happening there? Oh, well, if I understand what kind of tissues are working, I can then start to wrap my brain around what might support those tissues, right? So this is really just reclaiming our own anatomical understanding. Okay, that was a little trajectory as to who lives in the pelvic bowl in terms of a tissues perspective. But then we also have all of our organ matter. And our organ matter is, many of us have heard specifically of the womb, but also like the lungs and the diaphragm. They are muscles, right? They are muscles. They're not, and they are muscles and they're organs, right? But if we're talking about the muscle tissue, right, it is often called smooth muscle. And smooth muscle is just muscle tissue that has this interweaving with connective tissue cells in a specific ratio. meaning it's able to move, but it's also quite stable. So like the lungs are an excellent example, is they're very stable. There's like a firm container, right? And they're not tethered by like ligaments, right, to the bones, right? It has a different ratio because all the stabilizing cell material, all that connective tissue is interwoven with the muscle cells. And that's what makes the lungs and any muscle, any organ that is made of smooth muscle have this particular sort of shape and integrity. Okay? So the bladder, the rectum, and the uterus are all organs with a high smooth muscle content, meaning in our pelvic bowl, we have these smooth muscle tissues. We have our skeletal muscle tissues, which primarily make up the pelvic floor, but also the psoas, right, and other tissues in the pelvic bowl. And then we have our connective tissue, which are all the sort of like tender little ligaments and tendons, I put in quotes due to our previous discussion. And that's what's making up the tissues. Okay, so why does this matter? Having ability for those tissues to do their primary actions is crucial for prolapse to be, for pelvic support in general, and therefore for healing prolapse. So the ability from the muscles in the pelvic floor to be able to do their primary function, the skeletal muscles, which is supplicity, to expand and contract, requires mobility of those tissues. So how this is related to prolapse resolution has primarily to do with the breath. Meaning our pelvic floor is a diaphragm and our respiratory diaphragm lives within our trunk, right? And they are connected within the same connective tissue rungs. So the respiratory diaphragms, meaning the diaphragm that's up here, right, all inside our rib basket that allows our lungs to expand and contract, moves in tandem with our pelvic floor diaphragm. So as we inhale, everything moves down. And as we exhale, everything moves up. This is the primary function. Inhale, diaphragm moves down, pelvic floor moves down. Exhale, diaphragm moves up, pelvic floor moves up. Okay? What often occurs is what's called reverse breathing, in which case, when we inhale, we like suck in rather than expand. So the respiratory diaphragm would move up on the inhale, right? And then the pelvic floor diaphragm would kind of not really move, or maybe move up with the respiratory diaphragm. Then you would exhale and everything would draw down, or this wouldn't really move at all, right? So that would be a lack of pelvic mobility and this inverse movement in the diaphragm. As we have spoken, that movement of the tissue, specifically movement of the muscles, is crucial for maintaining integrity, meaning we all know this. If a muscle doesn't move, right, it's going to atrophy. It's not going to maintain strength and tone and vitality and lymphatic movement and blood flow. So no matter what we do in terms of our exercise or healing prolapse, if the way we breathe is not encouraging pelvic floor movement, then the 20 minutes of exercise that we do, if we're then sort of spending every waking moment of our lives doing the opposite, there's no wonder that 20 minutes of, Kegling is not going to resolve our prolapse. So let's have a little example here of diaphragmatic breathing and pressure control. So everyone bring your hands to your ribs, right? So your side ribs, and some people bring their hands to their waist. Don't do that. Find your ribs. It's kind of at your bust line. And as you take a breath in, can you feel your ribs? And I have my thumbs around the back and my fingers around the front. Can you feel your ribs, specifically your back ribs underneath your thumbs, widen into your hands? So inhale, everything widens. And then exhale, those ribs draw towards each other in the front and down in the back. I'll say that again. So inhale, ribs widen. Exhale, frontal ribs draw in, back ribs drop down. One more just like that. Inhale, everything widens. And exhale, everything drops, or front ribs draw in, back ribs draw down. Good. Now bring your hand to your low belly or your womb. As you inhale, can you widen your ribs? So just same breath, inhale, widen your ribs. And now exhale, maybe blow out birthday candles, or like, it might be easier. Feel your frontal ribs draw towards each other and your back ribs draw down. Let's do that 2 more times. So inhale, widen. Exhale, you knit, back ribs drop. One more inhale, rib basket widens. And exhale, knit the front ribs, back ribs drop. As that's occurring, we're likely feeling some movement back and forth in our low abdomen. It's subtle. There's not like a ton of movement, right? But in a patterned pelvic floor diaphragm, functional movement pattern, right? Or an optimal pattern, our low abdomen and our womb is gently, and I mean gently, receding towards the spine as we are exhaling, right? So we think as we breathe out, the low belly gently moves back. Why this would be occurring is as the diaphragm, right? As we exhale, that drawing in, the diaphragm would be moving up, the respiratory diaphragm, and therefore it would be pulling the pelvic floor and all the whole pelvic bowl up as well. And as this tapering up happens, right, it gently firms, right? Thinking if here's the front of the abdomen and this is the pelvic floor, as this pelvic floor lifts up, this is gently drawn back in relationship, right? So this scenario. And if we are breathing consistently in that pattern, meaning we develop that breath pattern to be happening autonomically, so without us having to think about it, is going to have an incredibly supportive effect for healing our prolapse, because it means every breath we take, we're actively supporting the healthful muscular and connective tissue movement within our pelvic floor, right? So if we're interested in healing prolapse, that's why we're here, it always begins here, right? It always begins with this basic diaphragmatic breathing practice. Why this is so important is often the opposite is what we do, meaning we inhale and suck it in and exhale, let it go. Which if we just take a second, that's nuts. Why would we get smaller when we fill with air? When we fill with air, we should expand, right? And when we expel air, everything should hug the midline. But so often we have this opposite actioning, this opposite breath pattern. This goes hand in hand with, right, our tucking of the tailbone, right? So if we are interested in like sucking up our low belly, often what we'll do is upright the pelvis. We'll tuck the tailbone to zip up these skinny jeans, because rather than allowing the womb to spill forward, right, and allowing the softness in the frontal abdomen, which would have this supported pelvic posture, right, we then zip everything up. And more often than not, that happens on the inhale, where you're like, let me suck it in, right? And so this relationship between chronic breath pattern and posture, this is huge for prolapse prevention as well. Because if we are in a culture where, I danced my whole life and have been a yoga teacher, I am right there with you, right? I have managed this myself, having not yet have children, which is why I'm super interested, right? But is in creating a bony alignment that allows for this breath movement and postural shift to be possible. So if we're forever tucking our tailbone in this shape, it makes it very hard for us to breathe diaphragmatically, because we're limiting the ability of our pelvis, of our pelvic floor, to move up and down, because we're congesting in the whole bottom musculature of the pelvic bowl. So if the pelvic floor can't move up and down, and then we're sucking the abdomen in, all of a sudden we've just created tension, right? Created tension within the whole region. Another way to think about this is if you are just hugging back, right? So if we just take a second and just kind of hug in the abdomen, if that isn't happening on the exhale, there's increased pressure. And this is where we're going to talk about pressure management. So pressure management is like a term that's thrown around and can sound very like sort of scientific-ish, right, when we're talking about prolapse, but it's actually quite simple in the sense that when we inhale and bring breath into the lungs, we increase pressure in the lungs, right? Of course, there's a pressure increase as we're breathing in, right? And then as we exhale, right, that is decreasing pressure. So we're just having this consistent ebb and flow that goes with breathing. If we are inhaling, so creating an increased pressure environment, so we're full of air, and then we suck back, right? We bring the abdomen back. What's happening is there has to be somewhere for that to go. And if we're inhaling in the diaphragm has moved down because that's how you inhale. The diaphragm draws down in order to inflate the lungs, right? And then you're firming the abdomen back. The contents of the pelvis have to go down. There's literally no place else for them to go. We've created an environment where the pressure is forcing our pelvis, forcing, some degree of pelvic organ descent, because it can't go up because all of those tissues are moving down by the nature of the inhale. We then have this increased pressure. So everything is doing this, right? We're pushing in the belly. Think your nose is over here, belly button's right here. The belly is pushing in. And so therefore all of this pressure is drawing down, which is why the action of sucking in the abdomen or doing abdominal work to quote unquote heal a prolapse is so often contraindicated and actually contributing to the problem, right? Because we're sucking in our belly, which causes the tucking of the tailbone, which creates that slide. And then you're adding pressure, and then add the pressure of maybe doing like a sit-up, right? And you've just created no place else for your organs to go except down and out, right? So when we're working with pressure management, can we be consistently inhaling in a way that is allowing that pressure to actually move in its intended direction, which in terms of breath means the pelvic floor would gently draw down, that's fine, right? But specifically the ribs would be moving, right? And so if we're really locked up in our ribs and in our back and right in this sort of frontal upper abdominals and all throughout our like bra strap region, if those muscles aren't able to be supple, then that's not going to be able to expand. And therefore, when we inhale deeply, we're going to have more downward pressure, right? Which is a contributing factor to prolapse. So often one of the key, after we have this arrangement of our pelvis, right, this arrangement of the bones, the next key is, can we work on true diaphragmatic breathing, which is going to mean often releasing some of these tissues in our ribs, strengthening the diaphragm, and getting there to be this natural and spontaneous expansion within the rib basket. And that might seem somewhat unrelated to the pelvic floor, but the more that can happen without us having to think about it, it means the ribs and the whole like lung and diaphragm tissue will be in this rhythm that is supportive, right? And then as we start to, work with that and feel as though we can breathe diaphragmatically, we then begin to teach, if it's not already happening spontaneously, this, belly back, pelvic floor up, belly back, pelvic floor up, belly out, pelvic floor down, belly out, pelvic floor down. So we see this is literally a depressurizing situation, as opposed to in and down is creating descent, right? So if you're like, okay, but what do I do? Because I was here to learn the 3 keys of how I'm going to heal my prolapse, right? The first one, untuck your tailbone, right? Untuck your tailbone and soften your abdomen. Because if that's not happening, then the rest can't occur, right? The second key would be learning diaphragmatic breathing. So how do we expand the ribs, right, and draw the ribs in, and how do we allow that to move with the belly, right? Because that will over time allow for this upward lift of our pelvic floor tissues. Okay. So the third key to healing pelvic prolapse is being able to maintain key 1 and key 2 while adding functional strength, right? So if we're wondering, I want to be doing exercises, so to speak, often just these 2 are super tiring, right? I see so many women that are really, quite strong in some capacity. We ask them to untuck their tailbone and can they stand like that for a 5-minute Zoom call? And they're like, my low back is screaming. Like, this is hard, right? And what I mean by that is if we're going back to this pelvic model and we're in this shape, right? In this adjusted female neutral, the musculature of the low back has to fire in order to keep the spine in this shape. The muscles of the glutes also have to fire. I like to kind of speak as though they could like plump off the bone as opposed to like strap to the bone, right? And if they were kind of strapping to the bone, right, this would create this often, like flattening of the buttock and drawing down of the tailbone. I will say that this is all also incredibly related to chronic low back pain, sciatic pain, tailbone pain, painful sex, pudendal nerve entrapment, like all of this is relevant, right? Which is why we so often see diastasis, pelvic prolapse, painful sex, bladder incontinence, and constipation, right? We see them all together and we're trying to look at why that might occur, right? So, because all this compression that's happening. So having this orientation requires some functional strength, and building that functional strength is going to be crucial to being able to maintain this over time. Maintaining it over time, along with healthy breath, is truly how we're going to resolve prolapse, because it's what we do all of the time, not what we do for 20 minutes of exercises. It's going to create lasting pelvic change, which, might be like, oh, but I wanted to do exercises for 3 weeks and have my prolapse improve. Newsflash, this will likely improve your prolapse in 3 weeks. And over time, it's going to create a huge shift, not just in your pelvic floor, but muscular, skeletally, respiratory, right? Through our entire body, which that's amazing. And often healing our prolapse can be the key to actually having better overall structural integration and function of our female physiology, which is why I love to say prolapse is not a pathology. And all women who have given birth have some degree of pelvic prolapse, all of us, because it is a physiological requirement of giving birth vaginally, right? Some tissues have to move down, right, in order for the baby to be born, even if only temporarily, right? Also, the actual womb literally moves lower in the pelvic bowl, specifically at gestation, like at term, right? So you're having this pressure down, the whole womb and uterus is moving down. By a very simple definition, that's prolapse. It just means the downward movement of our internal pelvic organs. So I would never diagnose a woman postpartum I would never diagnose a woman with prolapse at 6 or 8 weeks postpartum. It's like, no, you're in a healing phase, right? You are restoring function. This is not a pathology. This is something that we all can do to be bringing more pelvic tone and health back into the body. And of course, I would say this, I know some of you haven't given birth or are watching this for other prolapse resolution, and for prolapse resolution for other reasons other than childbirth, but I know that the majority of women are interested in it from a childbirth perspective. Okay, so what does this mean for our strength training, right? For our strength training, one, diaphragmatic strengthening, right? So how do we strengthen the diaphragm? One, take deep breaths and do it consistently. And by deep, I don't mean super fucking deep, that's going to increase pressure on your pelvic floor, but just actually breathe. And it can be kind of tiring to just inflate and have the movement of the lungs, right? If you are someone who wears bras, which we're going to talk about why, I try to not be that woman as often as I can, right? But I am, athlete, recovering fitness instructor that wore sports bras every day of my life for 10 years. What did that do? It really, right where you're holding, it compressed my rib basket. I was like strapping it together with a resistance band. And there, I just limited my mobility, right? It just is creating from simply our bra choices that, lack of lateral rib mobility. So if you are wearing a bra, use it like a resistance band, right? Open into it. Like, can you spread that, right? And sometimes I'll teach it that way, right? I used to, or sometimes, if you're not doing that, just putting actually a resistance band around your ribs or even just like a yoga strap and working to press out. That'd be the primary action. The secondary action that I would work in a functional movement perspective would be drawing the ribs together on the exhale. So we just talked about the inhale expanding, crucial, specifically the back ribs, right? And the exhale, bringing our front ribs together. So if you're watching this, right, just that shh breath, and you can sort of see, shh, right? My ribs are moving down. The key thing there, however, is when your ribs move down, can you not tuck your tailbone? Which so many of us, as we draw our ribs down, I'm just now slouching all the way from the bottom of the tailbone, right? I see some nodding here on the webinar and you're like, how do I do that? Practice. And we'll get to that in a minute. But if we're talking about the actions, right? And when I'm interested in teaching functional movement, I'm interested in teaching to actions rather than postures, because you can do down dog doing all these actions that are great, or you can do down dog and doing all these actions that are harmful, right? It's not about the shape, it's about the action. So the actions that I'm interested in are widening of the diaphragm, right? Drawing down of the frontal ribs. So we would say this is diaphragmatic mobility, really, both expansion and contraction, right? The tractioning of the pelvic floor. So the untucking of the tailbone. And what generally supports that is posterior chain strength. So we're talking back, butt, and hamstrings, right? Back, butt, and hamstrings. So teaching those muscles to contract. For me, what that often has looked like is actually strength training and strength training with weights, which I know is something that many of us are really concerned about doing, specifically if we have a prolapse. We're like, oh my God, I don't want to do that. I don't want to add more pressure, which is why this is the last of the 3 keys, right? Because the first 2 have to be in place. We have to have some ability to be able to breathe and maintain that adjusted female posture before we add weight, right? Because otherwise it's all going to fall apart and then our weight will actually be increasing our pelvic descent. So the third key is, can I maintain this while then adding some weight? So what that might look like, and this is further down the road, right? This is further down the road. And so, maybe originally we're talking about just holding a bridge pose. We're talking about, actually physically tipping, right? Our pelvic organs, right? If we think of a bridge pose, you're in this shape, right? And sometimes you can do a bridge pose with your tucked tailbone. How many of us have heard that? Extend your tailbone to the back of your knees, right? This like yoga cue that many of us have heard. I say, right? Lift from the top of your sacrum, right? Let your tailbone hang down, right? So you're having this tractioning, and then breathe, and you're having your all of your pelvic organs be sort of tipped up and out of the bowl, right? And in that way, in this sort of inverted shape, strengthening the glutes. So like, bridge lifts or single leg bridging. That would probably be in addition to diaphragmatic breathing, right? Diaphragmatic breathing with pulling the heels in and out. These are all of the actions that are going to be lay the foundation for strengthening after a prolapse, right? And what is helpful to know is that you can just continue this. So I wouldn't say like, oh, start, deadlifting and doing, heavy squats. Like, no, but eventually, yes, to deadlifts and other hamstring strengtheners and low back strengtheners. One thing I'll mention here is I do not encourage deep weighted squatting, potentially ever, right? And this is many would find controversial. It's like, oh, squatting is great for women. Squatting, especially like squatting with a squat rack. And if you're inhaling down, you're literally like inhaling, right? So everything's widening, your pelvic floor is widening, and then you're weighted, right? That's a lot of downward pressure on the pelvic floor, right? And so to then, gather all of that up to lift, more often than not, right? The pelvic floor is sort of the last to be recruited because everything else has to fire, right? In order to like make that really challenging action occur. So down the line, I'm a huge fan of single leg squats or like split squats, right? Like any like lunges with weights, things that strengthen the glutes unilaterally rather than bilaterally, because they're not just putting a ton of open downward pressure onto the pelvic floor. So in terms of what these actual actions are and like what the trajectory would be, that is something that I teach and that I work with for women who want to be like, okay, but what's like week 1 of my prolapse? What's week 2 of my prolapse? What actions do I want to work with? Right. That is absolutely programs that we can assemble. And they have, they're specific to also what type of prolapse are you healing from in some regard, right? In sense of if we're healing from a bladder prolapse or leaking urine, which leaking urine is almost always due to some degree of bladder prolapse, just note to self. Things that are forward folding in nature are literally going to put pressure on your bladder. So I know tons of women that literally only leak urine when they bend forward to pick up their babies. So therefore, we're not going to be putting a deadlift into someone who's healing from bladder prolapse. Versus if we have maybe a rectocele or a rectal prolapse, I mean, it's going to be supporting the rectum from behind. That means me plumping these muscles can actually be introduced maybe sooner for someone who's healing from rectal prolapse than it would be for someone who's healing from a cystocele. However, in general, like kind of up into the point of doing like strength training with weights, everything that's healing for one type of prolapse is going to be healing for another, right? And it starts with these basic principles of pressure management and functional strength. So if you're like, okay, but what do I do? If you have key 1 down and you have key 2 down, we're going to start with something as simple as just strengthening your glutes, right? And maintaining a low back in like integration or like low back muscles working. So walking around with your tailbone untucked, doing like maybe mini pistol squats on one leg, doing bridging with your tailbone untucked, Stretching your calves can be really useful because if your calves are really locked short, all these come all the way up, right? That fascial line comes all the way up into the back of the pelvic floor. And also just noting if your whole situation tends to be slung forward, right? And if that's the case, just drifting the pubic bone back so your hips are actually over your feet, right? Rather than pelvis forward, right? And doing these postural adjustments. So it's sort of the opposite of, shoulders back, lift the chest, straighten the legs, like good posture, right? Which is of course based on male physiology, right? And instead, like vagina in and back, heart in and back. The sort of Cliff Notes version is like shoving our sexual organs forward, like shoving our breasts and vagina like forward, like towards the world, towards men, we could say, is like not actually what's supportive for our female physiology. And so like our vaginas and our breasts, our sexual organs as women are actually for us and need to move into the body, right? Which that's amazing and epic. So those are the 3 keys that over time absolutely can create incredible pelvic prolapse resolution. I'm going to just mention here my sort of fourth key, because I think we have a little bit of time before we get into questions, which is sexual arousal, right? So sexual arousal of any kind and orgasm create a phenomenon called, I don't know what I would call that, an action. It's phenomenal, but an action of cervical flight, which means the cervix moves up in the vaginal canal. So in penetrative sex, many of us have probably had this experience where, you feel like there's more room, like you feel like you can actually like fit something into your vagina, where often if you're like reaching up, you can, in the shower, you can like feel your cervix, right? But then when you're having sex, you actually can have deeper penetration. And that is created by this action that happens upon arousal. And we won't get into the hormonal blueprint of arousal and how that creates this action. That's for another day. But the result is the cervix moves up, right? And that moves up because the uterus moves up, because the cervix is a part of our womb, a part of our uterus, right? And so that uterine mobility, right, that cervical mobility is exactly what we're always interested in creating, right? This ability for the muscles to move within the pelvic bowl. Also that upward lift, like, of course, that's the whole point, right? We want things to be moving up, and arousal creates that response. Often orgasm, and specifically cervical orgasm, but other types of orgasm as well, have this, many women describe it as this undulation or this pulsing feeling that happens, right, within the whole pelvic bowl. And that is actually that. It's like this pulsing up and in of all of our uterine tissues. And then that cervical flight can often be maintained depending on a variety of factors that, whatever, we'll leave it there, depending on a variety of factors, can often be maintained for several hours, or for certain women for days, right? You would actually have a shifted uterine and cervical placement as a result of arousal and orgasm. And many of us have actually felt this sort of anecdotally, like your pelvis actually feels different, like you feel more mobile. You might feel more comfortable in your hips after having good sex, right? Because you're often having a true internal shift of the placement of our pelvic organs. So this is where something like masturbation, right, specifically if you're early postpartum, that is resulting in arousal and cervical lift, can be an incredibly supportive tool for healing prolapse, because we're using our body's innate, ability to move these tissues, right? Also to draw blood flow to these tissues, to draw lymphatic flow to these tissues, all of which we know creates more resiliency. The more tissues move, the more blood flow they have, the stronger they become. And this is true whether it's your bicep or your vulva, right? And so having this as a consistent practice can also be incredibly supportive, right? And so if someone is sort of wondering, like, what's the first thing? I'm in my first 40 days. I'm like, masturbation, right? That is the first thing, because you can do it laying down, you can do it in bed, you can do it with your hips propped up. So you're in this subtle tilt, like kind of tipping your organs up. And masturbation specifically with breath, right? Because we also know that holding our breath as women, many of us has a relationship to pleasure, right? It has, that holding breath is like, sort of wrapped up in orgasm. And some women have to hold their breath to orgasm. Some women can't orgasm without holding their breath. we're not going to talk about that relationship too much more here, but we'll suffice to say that we know there is a relationship. And so being able to just begin having full diaphragmatic breaths in association with arousal is an incredibly powerful tool for pelvic health overall and pelvic integrity for both prolapse healing and prevention. So maybe next time this webinar will be called the 4 keys to healing pelvic prolapse, and it'll be an hour and a half, so that we can get into that more fully. But that leaves several minutes left for questions. So I'm going to answer some of the questions that were in the chat. If you want to pop your question in the chat right now, that would be wonderful. And I will also be answering questions that were submitted from the women who knew that they could not attend live. So I'll be going in order. Okay. So the first question I got, love this one. Can twerking help heal my prolapse? Probably, right? Love that. And I think going back to these keys, like, yeah, tissues that move are tissues that move, right? And so the more, and I have to say, I can't actually twerk. I have tried. I will continue to try. I know I will learn at some point. But the ability to have sort of essentially the like looseness in the hips, right? That like lack of restriction is often linked to, and this isn't just true for twerking, this is true for, you know, dance in general, but let me take that back. Not dance proof to tuck your tailbone, which is potentially like all of jazz, tap, ballet, and modern, which is what I did. So, you know, excluding the majority of dance that most of us probably did, but like in, you know, other dance modalities, something like belly dance, or maybe like salsa or bachata or merengue, like there's other dances that have this kind of untucked tailbone hip mobility, right? Which all of that is, yeah, can be super supportive from a muscular perspective. Can severe prolapses, are all of them able to be healed? So my first thought is everything can be healed, right? And what healing means is different for people, right? But certainly, you know, everything is, like, I'm not gonna say anything is impossible. I'll also say that quote unquote healing prolapse can be somewhat of a misnomer in the sense that it's a part of our body that is forever moving in adjustment to whatever it is that we are doing. So if, like, you know, did I like heal my, you know, knee injury? It's like, well, did you, I mean, I did all the PT and it felt way better. But then if I, you know, I don't know if you're over the age of 30, I feel like, and then if you stop doing PT and stop moving, your knee's going to hurt again. Like, it's not like we just get to not actually continue to care for our bodies, right? That this is all kind of part of the continuum. And if I continue doing my knee PT for the next 10 years and progressively added more to it, it might be stronger than from where I started, right? And that is like a trajectory of healing. And I would say that trajectory of healing is available for everything that we're healing in the body, prolapse included, as opposed to I had no prolapse and now I do, and then I healed it and now it's gone. That's a little too linear to actually be truthful in terms of any form of biological healing. So it's always, and that kind of gets branded sometimes. It's like, well, that's management. And I'm like, it's not management, right? It's healing. So that was about severity of prolapse. I will say, like, yeah, I mean, quite severe prolapse, which I would say, you know, I've worked with some women who are in their, you know, 60s or 70s who are, you know, their only diagnostic is to get a hysterectomy because their organs are literally dropping out and down through the vaginal canal. That is quite hard to heal at that stage, right? But that doesn't mean that if they had, you know, almost always those prolapses resulted after childbirth, right? And then an unsupported postpartum, and then not actually learning how to move and reintegrate. So was that, you know, was that prolapse healable? Absolutely. You know, if I'm seeing someone for the first time at 75, because she has I just had a client like this, and she was like, you know, you know, OB-GYN told me I'm going to have a hysterectomy in a month because this is really bad. And someone sent me to you. I'm like, okay, you know, I think that I'm never going to say that nothing's possible, but that is going to be much more challenging. And I would say, but specifically in premenopausal women, it's absolutely something that you can heal. Another circumstance that it can be challenging, I think is worth mentioning, is things that are iatrogenic, meaning that they're caused by medical intervention. So, yeah, I mean, women who have had like pelvic surgeries that were really done very poorly, right? Or non-surgical site issues. I was speaking with a woman who went in to have a labiaplasty and they accidentally cut her nerves, her clitoral nerves, and she has no ability to be aroused. And this was starting at age 17. So working with her, right, like just the whole function of arousal and cervical flight and how everything moves is very different, right? And that would be another circumstance. So I'm not going to say it's not healable. It just, there are complications for sure. But I've only ever seen that in, often like uterine or pelvic floor surgeries that are done poorly, right? Which is unfortunately, I would say the majority of them. So that's another talk, but I think we'll leave that there. And then I will get to your questions live. I promise. I'm just going to go through this list and then we'll get through the ones that are here in the room. Pessaries. Someone said that they have a pessary, and is that, talk about pessaries. So for those of you who do not know, a pessary is a ring, right? About, whatever, and this is situated up within the vaginal canal, right? To support specifically, though this is often for uterine, it's specifically for uterine prolapse, though some people use them for other types of prolapse. And the idea is that it's like pressing the sides of the vaginal wall, like out, supporting them. And there's like it's hollow in the middle, like a donut. And so the cervix can be sort of in the hole, but it's framed out wide, right? So it's having this support. So it's in that way holding the uterine tissue up from descending down into the vaginal canal. So pessaries are a tool, and they're not one that I personally use. However, I'm never saying that there are not moments for a pessary. However, what that is doing is it's putting the tissues into a shape that they can't support on their own. And if those tissues are held in that shape for a long time, then they're likely not going to, it's going to be less likely that they're going to be able to then support that shape on their own, because they are not in their primary action of simplicity, of movement. So if something's not moving, it's going to continue to weaken. So if they're just held out there, right, and there's nothing, and you wear a pessary, often women wear them for years, right, then it in over time can actually have an effect of worsening a prolapse because it's minimizing pelvic muscular movement. That being said, I would say I would choose pessary over hysterectomy, right? And I've definitely worked with elderly women who were having really horrible prolapse symptoms. We're told they were gonna have to hysterectomy. We did a lot of work. She got a pessary and she's able to keep her womb, which is incredibly important, right? 40% of American women will have a hysterectomy before the age of 80. Imagine if we castrated 40% of American men, literally cut off their balls. This is what we currently do to American women. So this is horrifying. And of course, these are not only our organs of sexual pleasure, but also our organs that play a huge role in hormonal production and cycling, even postmenopausal. So pessaries are a tool. And I would say they're a great tool to be used at that time. I would also say I had another client who was an Olympic runner. She ran very, very fast. And when she was running that quickly, at like the end of her races in that like circumstance, she'd had 2 kids. She was like, I can't hold my bladder. Like I'll just pee myself. And under that degree of physical duress, right, it was going to be unlikely that she'd be able to control her bladder. And so her interest at that point was, she's like, I want to maintain Olympic level times. And like, if that's her preference, like, I'm not going to say that that's not her choice to pursue that as opposed to pursuing like, pelvic integrity at this time. So a pessary was a good choice for her on like race days, where she was going to be like giving it her all, right, and not actually like particularly focused on that type of pelvic health and integration. I would say that over time, having that pelvic integration might actually help someone run with more speed and swiftness. But I'm not an Olympic track coach, and that's not what her coach thought. So that's where that one left. But in terms of using a pessary postpartum, I would instead have your ability to maintain your pelvic support, not having that feeling of pelvic descent, maintain your continence, that is the indicator of the level of physical activity that is right for you at that stage of healing. So rather like, oh, if I wear a pessary, I can go running and feel great. It's like, maybe what can you do and feel great without the pessary, and work up more slowly to increased activity, rather than sort of starting off with that, which I will say that is a common thing that you go in 6 months. They're like, oh, we can give you a pessary, right? 6 months postpartum, which like, no. I mean, except for yes, and obviously women do whatever the fuck they want. I just, it's not necessarily a recipe for lifetime pelvic health and healing. And just a note on that, again, in the postpartum, we have, or in the pelvis in general, we have this structure called the levator hiatus, which is this horseshoe shaped structure, right? That is in the pelvic bowl, shaped like so, right? I can't really do it, but shaped like so within the pelvis. And it's often referred to as the biggest hernia point within the body. And hernia point just means like where things can like bulge in and out. And our levator hiatus opens during pregnancy in order to allow the tissues to move apart so the baby can drop down. That levator hiatus remains open for 6 to 12 months in postpartum, right? So it's slowly, that horseshoe shape becomes more tapered, right? Which is of course going to give more support to your pelvic organs, which is why doing things that are incredibly like taxing on the pelvic floor in that immediate postpartum period can create prolapse where there wasn't one before, which is one reason why I would never diagnose someone with significant prolapse really in that first childbearing year, right? Because your levator hiatus is still open, right? So we're really just working to keep those tissues up and supported until it actually closes, where then you can have, more support. So just kind of working in that childbearing continuum, right? I also just like to refer to the phrase exogestation, meaning human species, we exogestate our babies for 9 months, meaning they're entirely dependent for a subsequent 9 months in the postpartum period. In all mammals, exogestation is when the baby can move away from the mom, right? Just even like physically. And for most babies, that happens about 9 months. The baby can physically crawl away. But if there's no ability for the organism to exist in any way independent of the mother, that's considered exogestation. And we as humans have that period, which I think, is very related to this, this levator hiatus, this, kind of coming back together of our pelvic bowl, kind of happens right along the times when our babies, we can put our babies on the floor, we can put them down, right? And it's like, oh, I can do something, because I can put my baby down. So that's all related as well. That actually leads very much, the next question was, what about close together pregnancies? You can totally have close together pregnancies. I want any woman to do whatever she wants, but the closer together your pregnancies, the more support that we need, right? So the more breath support, the more, the more sort of strength support, the more nutritional support, the more, we're not going to talk about how nutrition and like collagen levels and all of that relates to pelvic floor tissues, but that's a topic as well, right? So just nutritional support, muscular support, physical support, time, like all of that is absolutely going to be incredibly important if we're going to have babies close together, right? Because if we, have a baby and then have this open levator hiatus and then immediately get pregnant again, right? That's just an open situation that's supporting, it's not actually reintegrated and not supporting the weight of another pregnancy. So we really need to have a sort of extra pelvic support, extra meaning both additional and extra meaning the outside, right? So gluteal support, low back support, sacral support. They're going to help support that subsequent pregnancy. Also good breathing dynamics during a pregnancy, super helpful, as well as if we're thinking of one of the causes of prolapse being birth, how we birth our babies is also quite important. So if we are, on our back, right, like this, with our tailbone tucked, unable to, have it be released, with our knees pulled back, closing the pelvic bowl, right, numbed because we have an epidural, and then being told to push, right, that's creating a really tough situation for our pelvic tissues to be able to move with the breath, right, and us to be able to like feel and gauge where our babies are. So we see a much higher incidence of prolapse with women that are birthing in that, just like in that environment and in that way. So just something to be said for like if you are having like how your births are, right? And likely if you know, birth injuries are much more, and iatrogenic injuries are much more common in that specific type of birth. So, you know, then if you're, you know, healing that alongside a prolapse and then also pregnant and then like doing a lot, like this is where they can start to become far more challenging. I think that's why we can have a bad rap of being like, she had, you know, a bunch of babies really quickly and there's just like, it's not functional, which, you know, of course, spacing children is also, you know, a great choice. And if you aren't going to space your children, that's also a great choice if that's what you need for your family. And there's ways to do it with support. Okay, cystocele versus uterine versus rectocele. We talked about that at the beginning. So if that was your question, cycle back there. I will also say self-diagnosis is hard. Well, it's not impossible, but sometimes just the actual action of like reaching into your vagina, you're like smushing yourself in a way that can cause things to move. But, you know, generally posterior wall like moving into the vaginal canal, rectocele, anterior wall moving into the vaginal canal, cystocele, cervix being like closer than you remember, cervical or uterine prolapse. We didn't talk about urethral prolapses, but they're related to bladder prolapses. And okay, those are all the questions here. Let's see if we can get, there's 2 more in the chat in just a couple minutes. Do orgasms have the same effect with a prolapsed bladder, moving it upward, or only with uterine prolapse? Great question. Yes, they do have the same effect. Meaning, yes, whatever is, so going back to the types of tissue, right, which we have all of our smooth muscle tissue, our connective tissue, our skeletal muscle tissue within our pelvic bowl, they're all related, like they're all moving together, right? And so if something moves, something else is going to move because everything is connected. We can also think about this with the breath, right? If we're actually moving the breath, like the whole pelvic floor is physically moving, like all of these tissues are connected with the diaphragm. So lifting up the bottom of the pelvic muscles is of course going to lift the bladder. Also, for what cervical flight creates, and if we're talking about a cystocele, so meaning where the bladder is tipping into the vaginal canal, often we are, there is some diminished tone in the walls of the vagina, right? We might find like diminished striations, right? So it feels smoother, but it's also just not quite as buoyant, right? If we think of this tissue is moving up, it's going to actually make this a little more taut. The image that I'm having is like, remember those finger traps as a kid where you'd like put your fingers in and then you pull and they're snug on the fingers? I don't know if anyone knows what these are. I see some nods. Thank you. Right. So just that action of like pulling up, making the like the walls of the vagina firmer, that can also be quite helpful for a cystocele, for a bladder prolapse, because it's tipping into the vaginal wall, right? Because there's a lack of integrity in the structure of the vaginal wall to actually sort of hold the bladder in its place, right? As well as like, you know, maybe pressure down on the bladder due to that, you know, pressure differential that we talked about in key 2, right? Or just a general like heaviness and weighted down of all of our pelvic structure. So like breath, totally gonna lift the bladder, but also uterine lifting is also gonna firm the vaginal wall and therefore can be supportive for a cystocele. And for rectocele also. Okay, one more question. Can clitoral pain or discomfort or numbness be a symptom of prolapse? Great question. Let me think about that. So my first thought, I've never been asked this question. So there's that. My first thought is that I can't imagine that everything isn't related, at least like in some capacity, right? So if we're thinking about pelvic health overall, and we know that clitoral pain, okay, I'm catching it. I'm like catching the thought trend here. Okay, so clitoral pain or numbness, right, is often due to nerve entrapment, right? So for the nerve not actually having a healthy place to live, or being like, you know, fully kind of bound down in sort of banded connective tissue, maybe there's scar tissue, also, you know, related to our vagal nervous system. So our parasympathetic nervous system, if we're not in that parasympathetic space, that affects the innervation of the cervix all the way down into the clitoral nerves, right? So there's definitely some nervous system components that are related to clitoral pain and discomfort or numbness, which those are also all kind of different, right? I don't want to put them all in the same category. Like clitoral pain, like, is it hurting all the time? Discomfort, is it like, I don't know, do you have a vaginal infection? Numbness, like they're all sort of different. So I don't want to clump them together, but just in reference to your question, I also like that can be, part of it. So I think that there can be some nervous system relational stuff where we also know if we're in a super heightened nervous system state, that is also absolutely can be related to struggling more with prolapse, because there isn't this simplicity in the pelvic floor, because everything can be quite clenched if we're in a heightened sympathetic nervous system state. I'm also thinking of the pressure, and if you had specifically a bladder prolapse, though again, I'm just thinking this through in real time, it can sometimes be kind of resting towards your clitoral nerve. And like everything else, if you're just touching it, if you just touch your clitoris for a long time, it loses sensitivity, right? We often see this even with vibrators or something. We diminish clitoral sensitivity and nerve sensitivity with overstimulation. So just if there was something forever kind of resting on your clitoris, right, that might, the bladder, right, that might have a relationship to diminished sensation or numbness. I've never heard anyone talk about that. So, take that with a grain of salt, but we're also smart women, and we can just think through what we know about our own anatomy and make educated guesses. And I think just remembering that's all that anyone is ever doing, right? Medically trained or otherwise. And often their guesses are way less educated than even you are now after listening to this webinar. Just the basics of how orgasm is related to prolapse is, I've talked to a lot of pelvic floor PTs, and I've had that brought up to me exactly one time, right? So there is already sort of a dearth of resources. And that's not saying that there aren't amazing pelvic floor PTs, and they're often way better than most of our OB-GYNs who are often diagnosing prolapse in the first place. So I would just be interested, if that is your question, to be curious about your own body. And does, do you have if you are experiencing prolapse and it does start to resolve, how does that affect your clitoris? If you have more regular orgasms, how does that feel to your prolapse? And just be investigatory, because the idea that they wouldn't be related at all seems unlikely, because it's all wrapped up in our pelvic health and integrity and optimal function. Okay, and then if you are interested, some ways to work with me are, I take one-on-one clients every month. For the month of March, I still have 2 spots open for one-on-one clients, in which case I would meet with you every week for 75 minutes. We would do, kind of working through not just pelvic prolapse, though, sort of functional integration and pelvic health overall. And so often we'll see women for back pain who also have prolapse, who also are maybe wetting their pants, who also might have diastasis, who also are maybe having painful sex or haven't had an orgasm, or really anything, and how they're all related. So if any of those speak your name, obviously we can do a lot more one-on-one. And I talk to you in between our sessions, and we put together a program. And then, but the key to all of this stuff is that it takes practice, right? So I can tell you, these are the 3 keys to healing pelvic prolapse, but if we don't actually do them, they're worth squat, right? And so in that regard, I also teach workshops and retreats. I have a 5-day pelvic health intensive that will be in July, where we will be diving into all things that have to do with pelvic health and self-resolution for a variety of different pelvic health concerns, ranging from prolapse to back pain to incontinence to painful sex to repetitive infections, and how we can actually do so much for ourselves, and often with far more efficacy and grace than we are receiving from maybe traditional OB-GYN care. So if you're interested in that and want the opportunity to practice this stuff, that intensive will be wonderful. We're going to have 2.5-hour movement classes in the morning, and then lectures in the afternoon. It'll be in beautiful Vermont in the summertime. And I think we have 8 spots left there. And I teach webinars regularly on a variety of different pelvic health topics. So there's a lot of ways I can't to be in touch, and I can't wait to hear from you and work with you. So just reach out. You can follow me at Small Magic Birth and slide into my DMs. I'm quite responsive there, or shoot me an email. Okay, go on and heal your prolapses. You're gonna all do great.